So we're going to cover a lot of ground today, and probably start with the whole idea of spondyloarthritis. You know, we stopped using the word spondyloarthropathy because the SAA made us, and now no one uses that term except the American College of Rheumatology. And it starts with a concept called with axial spondyloarthritis. This is sort of the parent disease, and hopefully you'll understand this. Ankylosing spondylitis is a circle contained in the larger circle of axial spondyloarthritis, because there's also a group of non-radiographic axial spondyloarthritis that we'll talk about momentarily. Then we have peripheral spondyloarthritis, where people have not so much the spine. A lot of them have the spine involved, but a lot of them don't. And this includes people with psoriatic arthritis, the arthritis associated with inflammatory bowel disease, reactive arthritis, and those who don't quite fit into any of these categories, just called undifferentiated peripheral spondyloarthritis. Of course, that's ankylosing spondylitis. That's the classic host, which is a young male, and the classic bamboo spine. We start with a study that actually we carried out in the last decade, 2009-2010, which is the National Health and Nutrition Evaluation Survey. I was asked to do this by the NIH in 2003. We got the protocol together right when we were about to implement it with the NHANES group. They cut our funding off, and the SEA and Spartan got involved, came up with some of the money, as well as a few drug companies actually contributed, were very helpful. Centocor, which is now Janssen, Pfizer, Wyeth, and the like. But this was a study of 5,103 nationally representative people all over the United States. And lo and behold, what we found was 19.4 of them had chronic back pain. It's one of the leading reasons to see a physician. And what was interesting was that 89% were having pain at the time the study was being administered. And we looked at when it began, a pretty big proportion of these people had that chronic back pain begin under the age of 30. So that's rather striking. So we go from chronic back pain to inflammatory back pain. Let me explain what inflammatory back pain is. These are the various criteria that we're using right now for it, starting with Andre Kalin's criteria from 1977 up to the present. And basically, it's age onset before the age of 40 or 50. It's an early age onset. It's morning stiffness of greater than 30 minutes duration. The most discriminating question, this comes off of some work we did for the SAA, the SAA treatment, or rather a diagnostic algorithm that you can get on the SAA website. Improvement with back pain with exercise but not with rest. That's the most specific question to differentiate inflammatory back pain from mechanical back pain. And of course, alternating buttock pain, it was the most specific question. This is the best question. This is very specific, but it was not very sensitive. And so we have a good idea what inflammatory back pain is. So if we take that to that group of people that had chronic back pain, lo and behold, 7% of the U.S. population between the ages of 20 and 70 have chronic inflammatory back pain, especially the younger folks. Okay? And what's interesting is that even though the demographics of ankylosing spondylitis have men more commonly affected than women, there's slightly more inflammatory back pain in women than in men. And of course, Caucasians are the most commonly affected. The issue there comes to the axial spondyloarthritis. And the issue we have here is that it takes 7 to 10 years from the time that the back pain starts until it shows up on the X-ray. Okay? So this is the non-radiographic stage. And 7 to 10 years pass of pain before the patient will meet the 1984 modified New York criteria with having sacroiliitis seen in the X-rays and actually gets a diagnosis of ankylosing spondylitis. This is a big problem because now we know that 40% of these people, actually, that should be on the next slide. So that comes to what is axial spondyloarthritis. And this is the Assessments in Spondyloarthritis International Society. It's a group that was formed in 1995 in Europe. They came up with criteria for classification of axial spondyloarthritis, which is probably the best thing we've got right now. And that's for people who have chronic back pain, having either sacroiliitis on imaging. Imaging can be either on X-ray or on MRI. MRI is very good to make a diagnosis early on, whereas X-rays take 7 to 10 years. Or the presence of HLA-B27, and you only need one of these features if you have it on an imaging, but you need 2 of them if you have it on the basis of being HLA-B27 positive. And this is the best working definition that we actually have for axial spondyloarthritis at present. And so if we look at the prevalence of axial spondyloarthritis we used different criteria because the ASAS criteria weren't out yet at the time we did NHANES 2009-2010. We found a prevalence of axial spondyloarthritis overall of 1.4%. 1.4%, that's more common than rheumatoid arthritis. And it was interesting, 29 out of the 5,103 nationally representative people actually already had a diagnosis of ankylosing spondylitis made by a physician. So that comes to a prevalence of 0.57%, which is very close to the 0.52% that the NHANES 1971 to 75 found when they actually went out and x-rayed thousands of people in the general population. What was also interesting is that women were more likely to have axial spondyloarthritis than men. Okay, they're at a higher frequency, and of course the highest frequency being seen in Caucasians and lower in blacks. If we look, so I mentioned this before, but if we look over time at the current published studies, we find, lo and behold, at 10 years of having a diagnosis of axial SPA, still more than 40% had not developed ankylosing spondylitis. So a lot of people stay axial spondyloarthritis, but if you administer the questionnaires that we use that determine how functionally disabled they are or how much pain they're having, they're in as much pain and as unable to do things as people who actually have ankylosing spondylitis. So it's really important to try to get a handle on this early on, because as Dad, I'll show you subsequent data. You have the biggest impact on treatment and the greatest likelihood of reversing or of stopping progression of disease if you get involved early on. Okay, so let's go on to briefly talk about what causes ankylosing spondylitis. Genetic background is a major issue. Okay, up to 90% in family studies of the cause of AS thought to be genetic, and some things in the environment, it's not clear what they are, but I'll give you some evidence momentarily. Triggers the genes, and you get inflammation that leads ultimately to new bone formation and then the fusion of the spine that is so typical of this disease. So if we look at the genetics, that the prevalence of B27 in the U.S. population is actually 6.1%. It's 7.5% in Caucasians, 4.6% in Mexican Americans, and 1.1% in blacks. 90% of patients with AS are B27 positive. Less than 5% of B27 positive people in the general population actually have AS, whereas 20% of B27 positive relatives of AS patients will develop some type of spondyloarthritis. And B27 forms about 40% of the overall risk for spondyloarthritis, that identical twins are more likely to be affected than non-identical twins. And if we try to figure out what B27 does to cause this disease, well, these HLA-A and B, like everyone has 2 HLA-B genes, okay? Like I'm B8 and B55. All of the rest of my siblings are B27, B8. We got B8 from my father, I got B55 in my father, and then we got the B8 from my mother. And so what these HLA-A, B, and C molecules are supposed to do is they take a little piece of protein from inside the cells, they take it to the cell surface, and they present it to other white blood cells to get the immune response going. That's what it's supposed to do, but actually there's no evidence that's happening in AS. Another thing B27 has is that it has a tendency to not fold itself right when it's forming inside the cell, and that can lead to an unfolded protein response. It has a problem with, because it sticks to itself, and it either folds in a funny way and never gets out of the cell and causes inflammation, or the 2 B27 molecules stick to each other and form what we call a homodimer, and they get out to the cell surface, and they incite a response from natural killer cells, which is a type of white cell that can be pretty toxic when it gets going. The other thing is that people who are B27 positive have an advantage against certain kinds of infections and a disadvantage for other types. For example, if you're B27 positive and get infected with AIDS, you live twice as long. If you get hepatitis C, get infected with B27, you have a natural resistance against the virus. Even if you get influenza, the people who are B27 positive have a natural resistance against influenza. And that's why we think that certain Native American tribes have like 50% frequency of B27. We think that way back in history, there was a flu epidemic and wiped out all the B27 negative people. But there's other infections that people who are B27 positive don't deal with very effectively. One being chlamydia. They do badly with that. Salmonella, Shigella, which causes dysentery. Also, there's some data suggesting that people who are B27 positive may not do well with malaria, which is why we see very little B27 positivity in the hot parts of the world around the equator. So there might be something involved with this, and there probably is, in fact, something that's going on here in combination with something that isn't going on here that we know from the recent genetics. And then finally, HLA-B27 may actually influence the human microbiome, and I'll talk about that momentarily. Changes in the microbiome may predispose to ankylosing spondylitis. This is just another beat molecule that B27 raises the chance of getting the disease 80 times. If you have B40, it only increases it slightly, so it weakly influences whether or not you're going to get the disease, but it's not a big player here. What we now know is that we're up to 113 genes that we've now described. We've done the work, Matt Brown and all of us, and people, those of you who gave your blood have been genetically dissected, okay, because you're all part of this. And these are genes that are very important. IL-17 mediated immunity, that's interleukin 17, is one of these cytokines or chemicals in the blood that are very important, promoting inflammation. And of course, you know, there are now drugs to block that, like secukinumab, Cosentyx, or Taltz, which is exakinumab, and the like. The genes that are very important, CD8 T cell function. Genes are very important in loading those little pieces of protein onto the HLA molecule so it can go out and do its job. We discovered this back in 2007. It's a very important discovery. It's actually the most quoted paper in my CV. Genes that are involved in sensing microbes in your cells and other genes that carry a variety of other functions in the immune system. In fact, this is a list of all the genes, and what's interesting is that ASAS, which is the yellow circle, shares a lot of these genes with psoriasis, that's the big orange circle, or Crohn's disease, that's the red circle, or ulcerative colitis. In fact, some of the genes that are listed here are common to all four of these diseases. So we sort of think these genes are the ticket to the theater of spondyloarthritis, and these genes are the seat assignments. But there's a lot of common mechanisms. That's why there's also a lot of common treatments that are effective in dealing with these patients. Now let's talk a little about the microbiome. You know, each one of you is carrying around 2 kilograms of bugs in and on you. And they're mostly good bugs. These bugs interact with your genes to help you carry out a lot of very important immune functions. Let me give you some examples. There's a lot of carbohydrates that you eat that you can't digest. Well, those carbohydrates get passed on in your stool into the large intestine, and there those bacteria will digest them, and then you suddenly can use them for nutrients. Okay? Synthesis of vitamin K and most water-soluble B vitamins are actually done by those bugs in your gut. Okay? Dietary fibers get broken down in the large intestine by anaerobic intestinal microbiota to give you short-chain fatty acids, which are very important, not only providing energy sources, but also acting as signaling molecules in various tissues. So you and your bugs are good. So when you want to go and next time you get a cold and take an antibiotic for no good reason, or ask your doctor for one because you have the sniffles, you're messing with Mother Nature. Okay? And so with the healthy microbiome, it interacts with the genes, and you get a nice balance of the immune system and get health. But whether you have increased pro-inflammatory bacteria like Salmonella or Shigella or Campylobacter or things like that, you end up, because there's increased pro-inflammatory, this is the intestine. That's inside the intestinal wall. This is the lumen of the intestine, the tube. And there's the bug sitting at the surface there. Okay, so here's in the healthy state. This is where we have increased pro-inflammatory bacteria, which upset the balance and we get disease. Or if we have decreased anti-inflammatory bacteria, such as with the injudicious use of antibiotics. There's a bug called Clostridium difficile that is very important in this particular problem. You end up with the same result, which is disease. In fact, study from Matt Brown's lab, Marianne Costello, have shown that people with ankylosing spondylitis, the red bars here, have increases in certain kinds of bacteria in their gut and decreases in other bacteria in their gut. So they have a different microbiome than people who don't have AS. And Jim Rosenbaum has shown in his lab that actually we have that those bad bacteria are coated with immunoglobulin A, and that when he looked at B27 positive transgenic rats, that the presence of B27 seems to alter the bugs that are actually in there. So we're still trying to sort this out, how it actually directly influences how we get the disease, but it's a very hot area right now. And then, of course, there's the whole idea of AS being an enthesitis. The enthesis is the fibrocartilage where tendons and ligaments attach to bones. And so that gets inflamed. And then that's, we think, is the start of AS that ultimately gives rise to bone resorption, bone remodeling, and finally new bone formation and ankylosis. And that's the classic Achilles tendonitis that we see in a person with spondyloarthritis. So I'd like to talk a little about the PSOAS Dataset. A lot of the people in this room are actually part of this. And we're up to 1,354 patients right now. It's 80% white, 87% B27 positive, 72% male. And it's an educated cohort. We've already shown that compared to the general population, people with AS are more likely never to marry, never to have kids. It's a big impact on people's life. But what was interesting, you're going to love to see this. We compared in the NHANES study, which is the 5,103 people I told you about, we used the same questionnaire for the NHANES folks that you all filled out and in the NHANES. And we found that people with AS were just as likely to have ever smoked, but our AS patients were less likely to smoke than the general U.S. population. Of course, as you would expect, more likely to have uveitis, more likely to have Crohn's disease, or ulcerative colitis. But what was interesting, and I can't explain this one, they were less likely to have high blood pressure than the general population, even marginally less likely to have diabetes. This is a great one. Depression, 13.8% in the PSOAS cohort, 25.3% in the U.S. population. And so we found a couple important things in the study. This paper was just published in August. And we looked by ethnicity, whites, blacks, and Latinos, and we found that even though AS is a lot less common in blacks, it is much more severe. They had the same age of symptom onset, okay, and they had even though they had shorter disease duration than the other groups, so there wasn't a delay in diagnosis here. We were rather shocked to find they had much more disease activity than whites or Hispanics. They had higher CRPs, and most strikingly, we used this measure, we assess radiographic severity. Look at that, 38, an MSAS score, a mean score of 38 compared to 6.4 and 8.1 in the other ethnic groups. So when blacks get it, they get it bad, and just remember that. So it's part of the disparity that we're currently dealing with this disease. This is looking at, we have another cohort that I deal with in China, in Shanghai and Shenzhen, and we found they had less uveitis, obviously less joint surgery, but they had higher CRPs, which we thought was very active, which is very interesting. When we get to treatment, I'm going to go with that, because there's another issue that's a problem too. And this is the whole issue of opioid usage, which is a hot topic right now. It's, even Trump's talking about it. What's happened is that drug-induced deaths both have gone past automobile accidents as the leading cause of accidental death in the United States. And you know a lot of very high-profile people, Prince, Michael Jackson, Brittany Murphy, Heath Ledger, all the like, who basically died of combinations of opioids and other medications, all the way down to Bruce Lee. I bet you didn't know that Bruce Lee was on that list. He died of cerebral edema due to meprobamate. Meprobamate was a pre-benzodiazepine sedative. My grandmother took one every night when she went to bed. I remember that very well. Her Milltown. And if any one of you are taking Soma or Cara-isoprotol, yes, one pass to the liver, and that's meprobamate. One pass, and I'm old enough to remember when there was in widespread use, and with meprobamate withdrawal can be nasty when the people were taking higher doses. The ones we're really dealing with are the hydrocodone, the oxycodone, the oxymorphone drugs. And the problem we're seeing is the interaction with benzodiazepines, which is a big problem. And so much so that the CDC is basically saying non-opioid therapy is preferred for the treatment of chronic pain. This is 2016. In August of this year, they actually strengthened this language more. And as you know, those of you who have chronic pain and because that are taking opioids because of it are experiencing all the problems that are now with their doctors in that respect. In the PSOAS study, and this paper is coming out next month in the Journal of Rheumatology, we compared the patients who were not using opioids with those who were using intermittently versus chronic. And I don't want to spend a lot of time on this, but the most striking finding was that they were more likely to be taking other medications like anxiolytics and hypnotics, primarily benzodiazepines and the like, which can cause big problems when they are used in combination. In fact, if we looked at looked at our Chinese cohort, just to contrast our PSOAS cohort with the Chinese cohort, 961 versus 443 patients, the Chinese are much more likely to be taking NSAIDs, much more likely to be taking methotrexate or sulfasalazine. They were much more likely to be using a vine called tripyridine 40E, which actually is known to be anti-inflammatory, but has a high GI side effect profile. You can do what you want with that. Thalidomide, do you remember that? Well, that's the TNF blocker they use in China because they don't have access to TNF blockers otherwise. Also, they're much more likely to be using corticosteroids, which to us is a no-no. But then less likely, actually, out of 443, there was one person was taking tramadol. And so there's a lot of big differences in the way AS is treated in the two different countries. And if we look in the PSOAS cohort at the variety of factors that would predict those who are more likely to be using opioids, older patients, for some reason being married, I can't figure that one out. Smokers, people taking opioids are more likely to be depressed, to have more functional impairment than those who don't, to have higher subjective disease activity using a measure we call the BOSDI, and those of you who were in the study have filled innumerable ones of them out, but not objective measures of disease activity. There wasn't any difference in radiographic severity, but the anxiolytics and hypnotic usage was quite four more times likely to be using anxiolytics than those who were not taking opioids. So this is a big caveat, and it's a challenge in management. So talking about other issues with treatment, we seek, when we treat our patients, to be controlling the signs and symptoms of the disease, to be including disease activity, pain, morning stiffness, and fatigue, to allow greater functional ability with increased productivity, to prevent structural damage, and I'm going to be talking about this momentarily, improve quality of life, as well as to deal with the socioeconomic factors like sick leave and retirement and disability. This is an old paradigm that we use that has been updated considerably, but starting with NSAIDs, education. Depending if they have more peripheral or disease in the spine or in the joints, we might use sulfasalazine, which otherwise doesn't work here. Local corticosteroid injections, and finally biologics. So these are actually from the American College of Rheumatology and Spartan and the Spondylitis Association. They got together to form the recommendations for treatment of ankylosing spondylitis and non-radiographic axial spondyloarthritis. This was published last year. But for those with active AS, we strongly urge that our patients start by taking non-steroidal anti-inflammatory drugs. I'll talk more about that momentarily because I know you have concerns about that. I have very strong feelings about this, and we'll get to that. If in fact, we know that for axial disease, that the slow-acting drugs like sulfasalazine don't work for axial disease, but they only work for the peripheral joint manifestations, okay? But otherwise, if the disease remains active, we recommend going on to, well, these are 2 years old, so now we have the IL-17 blockers out also, but going on to a TNF blocker. For people who have recurrent iritis, now about 30% of people with AS have inflammation in the eye, but only 5% have a big problem with that where it keeps coming back. That 5% should not be using etanercept, okay? But the rest can, there's no problem. So with recurrent iritis, we recommend using a monoclonal. Now, these guidelines are strictly evidence-based, so there's no reason to think that golimumab or certolizumab don't work. But there's just no published data at the time these guidelines came up, so we recommended infliximab or adalimumab. But if they have inflammatory bowel disease, likewise, TNF monoclonals are recommended over etanercept. And if you fail one TNF blocker, you would recommend going on to another. I was on this panel. I was also on the panel for the European guidelines, and they recommend that if you fail a TNF, either another TNF agent or go to an IL-17 agent. We do not recommend systemic glucocorticoids. Okay, for isolated sacroiliitis, you could actually get an injection of glucocorticoid into the SI joints, or for the peripheral arthritis, or even for enthesitis, although we don't like to inject the Achilles tendon or the patellar tendon right here in front of the knee. We recommend the use of validated AS-specific disease activity measures, as well as exercises are very, very important. You're having a talk on physical therapy this afternoon. Listen to it. Every patient with AS should have a physical therapy referral. Okay? But we recommend NSAIDs in full doses, full anti-inflammatory doses. If they have stable AS, the recommendation is just use them when you need them. In fact, if you're using a TNF drug and your disease is well controlled, you could probably drop the NSAID. And of course, even for people with stable AS, if they're being seen for the first time, we advocate a physical therapy referral. Patients should be monitored with validated disease activity measures, as well as CRP and SED rate, unsupervised back exercises, formal group or individual self-management, education. All the others are very important. For advanced hip arthritis, hip arthroplasty is recommended. Actually, I'll say more about this momentarily. Physical therapy is known. It's been shown that people do much better if they undergo physical therapy. Supervised group physiotherapy is better than individual home-based. And of course, the combined inpatient spa exercise therapy program does better than all of them, but then your insurance aren't going to pay for that. They do that. They have a lot of that in Europe. Now, NSAIDs are where we start, because NSAIDs work a lot better with inflammatory, or especially with AS, than with non-inflammatory back pain. And so they don't work for mechanical back pain. They don't work so well. Again, as I said before, we recommend full anti-inflammatory doses, which would be like Celebrex, 200 milligrams BID, or diclofenac, 75 milligrams BID, or 50 milligrams TID, meloxicam, 15 milligrams a day, naproxen, 1 gram a day, or for those who take a leave, since in our cohort, that's the most common NSAID taken. That's 2 to leave in the morning and 2 to leave at night with meals, or Feldine, peroxicam, 20 milligrams a day. In fact, there are data from 2 studies. One was the Wander study in 2005, another is the Budubnoy study in 2010, that suggested NSAIDs alone can slow down radiographic progression when taken when taken on a daily basis, okay? Dennis-Bodubnoy looked more at dosage but found the same thing. And I'm going to show you some additional data along these lines. So we strongly recommend this. Now, a lot of you may be concerned about NSAIDs in heart disease or NSAIDs in kidney disease. Okay, well, there are a couple of studies now out that have addressed this question. Let's just do the bottom line here. The bottom line is that uncontrolled ankylosing spondylitis is far worse on your heart than full-dose NSAIDs. That the people who were taking full-dose NSAIDs had less heart disease than those who had their AS poorly controlled and were not taking them. So let's get real here. You have to understand that control of inflammation is the most important thing that we try to do in our patient with AS, because that is what kills the patient, okay? That's how they die prematurely. My older brother with spondyloarthritis had his first heart attack at age 52. He presented with cardiac arrest. Great stories the other side. It took him 4 minutes to get him back. He remembers the whole thing. Doesn't remember the cardiac arrest he had 2 weeks later, but he still has great stories of the first one. And to me, he's a walking illustration, because he was a slender guy, a high normal blood pressure, cholesterol 195. I mean, otherwise not a lot of risk factors, premature cardiovascular disease. He's had 2 heart attacks since, but he's doing well, thank heaven. We know that that's important. That, in fact, 50% of our PSOAS cohort never even needed a biologic, because they're perfectly well controlled with non-steroidal anti-inflammatories alone. And of course, as the guidelines told us, if the NSAIDs don't work and they have predominantly back disease or neck disease, we recommend going on to a TNF blocker. One's no better than the other. They're all the same as far as how good they are. I don't recommend one over the other. In fact, in my clinic, I let the patients choose. I just talk about them. There's actually 5. I don't have, I'm sorry, it's an older slide, but sertolizumab looks just like that. So there's 5 TNF blockers out there. They all are as good. The only caveat being with etanercept, if a person with the 5% who have the recurrent iritis, or if they have inflammatory bowel disease, etanercept's not a good idea. And of course, the effect in most patients remains over time. That's weeks, going out to many, many weeks, many years. So, and even in axial spondyloarthritis data from the Heibel cohort, as well as others, have shown that this is with adalimumab, but also with etanercept in the Desir cohort, or with tertulizumab. They've all shown the same thing, that even in axial spondyloarthritis, pre-radiographic disease, these drugs work. And in fact, if you profile the person who's most likely to respond to an anti-TNF agent, that's going to be the red dot line right there, and that's the likelihood of response. And that's the person with less than 20 years disease duration, right here. Less than 10 years disease duration, and an elevated C-reactive protein. So those with objective inflammation in their blood and with short disease duration, that's the ones most likely to respond. We showed the same thing in our study, where we showed that we got the best responses with short disease duration and with the drug used continuously. And actually, that's what we were looking at right here. But we were shocked is that there were data from Europe that initially said that these drugs did not slow down X-ray progression. Well, in fact, that's the paper we published in 2013, we showed that using TNF inhibitors halves the likelihood of X-ray progression. So that's not the case. The time we published this, the Europeans came after us and were throwing stones at us, and now they've confirmed it, so now they're finally happy. The other things, though, those who have more damage at baseline are more likely to get more damage, but with elevated inflammatory markers. Smoking is horrible. Nicotine is a pro-inflammatory chemical. It's a horrible thing to be doing. You need to stop smoking. And of course, those with lesser, the younger people are more likely to progress than older people with younger onset. A word about iritis. Tends to occur unilateral. It comes on very abruptly. It's in the front part of the eye. It's highly B27 associated. In fact, if you have a double dose of B27, if you get a B27 from each parent, so you have all your B27, your chance of having iritis is something like 50 times that of having a single dose of B27. People with iritis need to be followed by an ophthalmologist because we may not get all the information out of there. Now, the good news is very few people go on to develop visual impairment from the iritis we see with spondylitis. We also recommend using, our panel recommended using topical glucocorticoid drops at home so you can deal with flares yourself. And as I said before, a monoclonal over etanercept for those with chronic recurrent iritis. For the ones with just a rare episode, etanercept is fine. There is cardiac disease we see with this. This is the aortic valve. And what we see is this fibrous inflammatory bump that occurs in about 5% of patients with AS below the valve that causes retraction of the valve and can cause actually aortic regurgitation. Also, what sits right next to that base of the aortic valve is your conduction system. And so these people can present with heart block. And rarer things we can see would be pericarditis. I take care of 2 physicians who are B27 positive with aortic aneurysm, ascending aortic aneurysms. So these are all potential complications of the disease. Remember that a spine of a patient with AS is brittle and more likely to break than when the inflammation causes loss of bone and osteoporosis. So even with trivial trauma, neck fractures is a devastating problem with this. Spinal fracture can occur even after trivial trauma. It can be easily overlooked. Other things can happen. This is one, thankfully, rare complication of AS called Cowdy-Klein syndrome, but it's devastating when it occurs because there's no good treatment for it. So for people, we recommend that patients get formal group or individual self-management and education. Fall evaluation and counseling is very important, just like we do with the elderly, because if you fall with a brittle spine, that's a problem. People should be screened with DEXA scans. All of you with AS need to be screened with DEXA scans for osteoporosis, okay? Because you don't want to miss this, and this is treatable. Hip disease, up to 40% of patients with AS. Some people develop bone around the prosthesis. That's a problem. It's rather rare, but using NSAIDs can potentially slow that down. When a patient comes to you like this, it's sort of heartbreaking because we know that this patient functionally is going to have a lot of problems. There's operative techniques that are used to straighten the spine up. The one that's most likely or been shown to be most effective is the closing wedge osteotomy. That whatever it is, you want to make sure that you do this at a center with a lot of experience because the operative mortality and likelihood of paralysis is high. And so you want to make sure that you send the person to a place with a lot of experience with this. I send my patients in Texas to Pat Johnson at Cedars-Sinai, who is one of the best people I know for this. And I've seen some amazing results. Finally, some of the new drugs, IL-17 blockade has been shown to work at least as good as anti-TNF agents. The one that's FDA approved is secukinumab. It was approved at 150 milligrams sub-Q a month. A lot of my patients break through on that, and so I have to admit I'm using 300 milligrams a month, which is the dose that's advocated for psoriasis. And my patients, and those of you in the audience who are taking it, a lot of my patients are breaking through at day 20 in the month, and so I'm been giving it 150 milligrams twice a month. So far, the insurance companies haven't questioned it, but I write at the prescription 300 milligrams a month, and I tell the patient 1 shot twice a month and get away with it. Ixekizumab is actually Taltz. You see it on TV for psoriasis. It's been approved already. That's in clinical trials. That'll probably be out in a year or two. I know UCB has one. I'm blanking on the name of it right now. That's in clinical trials also. Interleukin-6 didn't work. Apremilast didn't work. Ustekinumab didn't work. Not very well. Xeljanz has their phase 2 trials complete, and it was effective. Okay, so more work needs to be done. We'll wait and see what happens here when the phase 3 trials come out and some of the conditions get looked at. But that's a pill. So that's a pill. And then Kineret didn't work. So I'll end right here and try to be available for questions. This is where I see our patients right there, and that 4th floor. And that's my academic office there. And the Texas Medical Center is the largest medical center in the world, like everything else we do in Texas. Thank you very much.